very much for joining. So this session is basically different radiological investigations we are facing every day, and they can give in a talks examination, and we have to give quick right answers in a no time. So I will be giving different scenarios because the talks examination or ASCII examination, it is a rapid fire type of examination. So I request the candidates who are appearing in a coming exam, so they should telling me in a rapid fire way, so we can be growing each other, and the things should be clear in their mind in the frontal lobe as well. Okay, so anybody in the audience can tell me what is the investigation that has been shown here? I request you to participate actively. So basically, it is a discussion class. जी Mohammad Ali bhai, Dr. Akil bhai, and everyone, you are
Sir,
encouraged
this
to
looks
answer.
X-ray abdomen pelvis.
Okay, you are telling that it looks like X-ray abdomen pelvis. So do you think that X-ray abdomen pelvis that is usually used for like radio opaque stone, and you know that all the stone are radio opaque except the xanthine and the uric acid stone. Okay, so I think it is not the simple X-ray because it is
IBU.
showing. Yes, it is IBU. So you should tell the full name because some candidates are just beginner. So
This is
everyone should be very.
basically the intravenous neurogram showing the pelvic calyceal dilatation. Uh, I can
Yes,
see.
it is a intravenous urogram basically. So there is a 32-year-old man. He has intermittent flank discomfort. Renal function is normal. So we have requested the intravenous urogram to assess the urinary tract. So basically, this is the study that shows that both kidneys should opacify and symmetrical nephrogram should be there. Calyces should be sharp and well defined, and renal pelvis should be looking quite good. Ureter should be looking smooth, not dilated, and ureter should be uninterrupted. And contrast should read in a good way to the bladder. Okay, so this is the first study that is actually normal IVU, normal intravenous urogram. It is not showing any pelvic kidney. It is not showing any dilatation in the ureter. So gradually we will be looking the pathologies. So it should be comparable in our mind for us. Okay. So next, uh, here I am giving you another scenario. A 40-year-old man, he presented with a severe right low into groin pain and microscopic hematuria. Okay. So this is the history. So what you can see, the renal calyces and the abdominal ureter and pelvic ureter and the urinary bladder. ये भी नॉर्मल है, ठीक है. इसके बाद this is normal. अब ये एक और है. Here you can see the left kidney is actually a pelvic kidney. It is low lying kidney. So these are three just example. So this is the another IVU for you guys. This is actually a scenario of that patient I repeated now. 40-year-old man present with a severe right low into groin pain and microscopic hematuria. Is anything that is pathological here? I think there is a delayed excretion on the affected side. You can see that too much contrast is on the right side. The nephrogram looks a little bit denser on the right side, and dilated renal pelvis and dilated renal calyces. And if you compare the ureter on the both sides, you can see that there is heteroureter, especially proximal to the obstruction, and there is a possible filling defect or radiopaque stone as well. So obstructive uropathy is secondary to the ureteric calculus. I want to show you another picture. So
Please wait. Just please the previous slide. Where is the level of obstruction here? At the bladder? At the bladder level, because all the ureter is dilated on the right side.
Yes, you are right that it can be on the VUJ. Sometime there are two stones, and one can be at the VU, sorry, at the pelvic brim level. So if
Mm.
I can see that it looks like something is problem here. So above
Yep.
ureter is too much dilated as compared to the lower ureter. But if you compare the right and left, you can see that the whole ureter looks dilated as compared to the left side.
Okay.
Okay, thank you. So this is another example. So some slides are not quite good, but actually we want to grab the concept. But here the obstruction level looks more beautiful. So can
Mm.
you tell me here?
The left kidney shows the dilated calyces and the pelvis and the proximal
Yes.
ureter.
The terminology is dense nephrogram on the left side. Okay,
Okay. Okay. Okay.
and dilated renal pelvis above the level of obstruction.
Mid ureter. Ah.
Okay, very good. And there is a possibility of the filling defect और रेडियो पैक जो है ना वो स्टोन इसमें लग रहा है फिलिंग डिफेक्ट यू कैन से ऑन द लेफ्ट साइड ओके
Mm.
but the contrast material has reached quietly good in the bladder so right sided contrast is being emptied here but the left kidney is still that has a outflow obstruction
Mm.
okay so again here you can see the again this is another beautiful picture
Mm.
what it is showing intravenous urogram okay so what it is showing right sided radio pack stone okay
Mm.
and
Okay.
level of obstruction and dilated pelvis and calcium system. Okay. So here you can see if the you can see the both the right and left kidney, you can see that there is a defect uh, that can be shown at the PUJ or just in the proximal ureter. Okay. Yes, this is another important question. I'm giving you a scenario. A 22-year-old patient has recurrent flank pain, and I have ordered the IVU. Can you tell me the intravenous urogram finding in this patient?
Here is a dense calcification on the left side in the left kidney. So maybe
Yes,
uh,
you cannot
nephrocalcification.
comment on the calcification because we have we have given the contrast. So this is not
Oh, yeah.
calcification where when you have given the contrast media. So actually, it is contrast accumulation
Okay.
and the
Okay.
left kidney. So can you trace the contrast
No.
further point from the pelvis downstream from the pelvis?
No. No.
Yes. So this is a common day question. It is a PUJ obstruction.
Okay.
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 So most of the time, multiple patients they present with a stenosis, stricture, and this problem. So here is a dilated renal pelvis on the left side with a dilated calyces, no or minimal dilatation of the ureter and abrupt narrowing. Okay, at the PUJ. So it is a too much delayed drainage. So we have a diagnosis of pelvic ureteric junction obstruction.
So how
Okay.
how, how will we
So I think if I am the examiner,
how will we differentiate between the calcification? It looks like a calcified kidney.
you are right, but you can see the contrast on the right side. So contrast is going as well as into the bladder. So because
Okay.
the contrast is present on the right side as well as in the bladder, so
So
this
that is
is
a
we
differentiator.
have not
Okay.
to whenever there is a contrast is present, you should tell it as a heteronephrosis. Yes, this is the
Okay.
point that especially you can look on the right side counterpart as well as the bladder. Okay, so
Okay. Okay.
otherwise, any new nephrology PG can call it that there is a stone in the bladder. So this will be just ridiculous.
Hmm.
Okay, so this is not stone in the bladder. It is actually the contrast medium that
Contrast.
is coming from the right kidney. Okay,
Okay.
so again here, again, okay, what is the
Uh,
problem here? Again, it is the same slide. 22-year-old
ah.
old man who has right flank pain, particularly after fluid intake. It is abrupt narrowing at the renal pelvis, and it is a PUJ obstruction on the right side. We cannot raise
Hmm.
the ureter downstream. Okay. So what is the problem here? Anybody can tell me?
It's
Yes,
a
it is also,
problem on both
you
sides.
know, that dilated pelvis on the left side. Okay.
And where is contrast on the right side in the ureter and
Dilated pelvis on the left side, brother.
and what about the right side?
Uh,
Here we cannot see the contrast in the ureter and the bladder.
bladder level is
Below?
not shown here. Actually, bladder is a little bit on the low side. And, this is the study that has been done after the 45 minutes. So actually, the right side has eliminated the contrast almost whole and whole, but left
Mm-hmm.
side still has a hydronephrosis as well as a narrowing. So the time of study is also important. But you are asking the contrast in the right ureter because there has been 45 minutes passed. So if there was obstruction, it should be dilated as well. So
Okay, okay.
there
So
should be double finding to correlate the problem on that side.
we have to compare the size of the both matlab pelvises and the
So it is again,
calyces and
it is
etc.
a yes, yes. It is a partial PUJ obstruction, partial PUJ obstruction. So and there is a narrowing और ये जो है ना आपने देख लिया ठीक है इसको और ये this one. Here I am labeling the things. So dilated calyx is normal
On the
pelvic
right side.
calcium system on the left side versus dilated on the right side. 33-year-old male with intravenous urography, 25 minutes film, dilated right renal pelvis, narrowing at the PUJ junction. So I have told you. So this was a actually a catch up of the previous slides. Okay. So here again,
Hmm. Right kidney is dilated.
ये क्या है
With
भाईजान?
again, this is a dense
And
nephro.
abrupt narrowing as well. Okay. PUJ obstruction.
On the right side is dilatation.
Dense nephrogram on the right side. Okay. So this is a new disease. I was unaware of myself as well. So if you see, it is known as S-shaped or reversed J appearance of the ureter. So it is called as retrocaval ureter.
Hmm.
So this is a 35-year-old man. He has chronic right flank pain and recurrent UTI. So right side has a hydronephrosis and proximal hydroureter and the medial deviation of the ureter. So it is coming, you can see towards the vertebral bodies. So it is a medial deviation or reverse J, or some people call it as a fish hook appearance of the ureter. So ureter passes behind the inferior vena cava here and then returns to the normal position slowly. And this is a IV intravenous urogram published one of the famous journal AGKD. So I have taken it from there, and you can see this is the that is the ureter that is taking another pass going mid infections
Can
as
you
well.
repeat?
Okay.
Your voice.
So if
We
you
didn't hear your
can
voice.
recover. Okay, so this is this is a case of retrocaval ureter. So this
Hmm.
ureter. So this ureter goes behind the inferior vena cava vertebral disc and then it returns back. So this is known as fish hook ureter or S-shaped ureter or reversed J-shaped ureter.
Okay.
Okay. So it
Oh,
leads to the infection. It was published in AJKD.
okay. Okay. Retrocable.
Okay. So coming to that is the problem. Yes, this is another very important question. So you can see this is a very difficult as well. She was investigated for the recurrent UTI. Okay. So if you can see the IVU finding, you can see that both kidney are lower than the expected position. Okay. So ribs are quite high, but this calcial system is on the down or on downside. So both kidney are lower than the expected position. If you can see the lower poles, they are pointing medially. Again, this is the abnormal fin. Ureters may descend normally after leaving the kidney. So it is a horseshoe-shaped kidney.
Again,
Okay.
repeat
So
please your voice.
uh, whenever they are showing you the kidney right position is here. Okay. Are you listening me, brother?
Just repeat. There was interruption in your voice, so please.
Can you listen me?
Yes, we are listening.
Okay. Okay. So can you listen me now clearly?
Yes, yes, yes.
Okay.
May,
So actually,
Assalamu
this is
alaikum.
the normal position of the kidney.
Wa alaikum assalam. Okay.
Walaikum salam, brother. Welcome. Okay.
I suspect that this may be.
So it is the normal position of coming midly.
Okay, okay,
These are coming toward the midly. So
okay.
midly, whenever the lower poles are coming midly, actually these are some type of horseshoe kidney. Okay, so
Horseshoe
both the
kidney,
kidney are lower
I
than the
know.
expected in a young. Yes, lower pole
Okay,
points midly and fusion across the midline. So abnormal orientation of the renal pelvis and calces, but the ureter then takes the normal course in these patients. Okay, horseshoe, always remember that lower pole are fused, especially in the medial area. Again, it is a beautiful picture of horseshoe kidney.
Okay.
Kidneys are lower lying,
okay. Very
both
clear,
kidney are
very
lower
clear.
than the expected, lower pole point. Thank you, brother. Thank you. So another picture, anybody can tell me what is the problem here? Lower pole are fused. Okay,
Yeah,
Hmm.
the
fused
kidney are
together with
low
horseshoe
lying.
kidney. But ureter,
Yes.
ureter is split. Any kidney has a ureter.
Horseshoe. Very nice, brother. So, ureter almost take normal course. So these patients present with the repeated UTIs and infections. Okay, so this is another important question. So I
Flex
request
ureter.
Dr. Akil.
But any
Flex ureter.
left kidney has two ureter. And
Yes,
right kidney also
what is the diagnosis
has
here?
two ureter.
Yes, it is a double ureter
This is
system.
basically a
Double
flex
ureter
ureter on
system, yeah.
the left
It is
side,
known as
double
on the
ureter
both sides.
on the left side, on both sides. Okay, okay. Yes, yes.
You can see, yes, duplex ureter. Dr. Mujib, thank you very much. So it is a duplex collecting system. So this is a 10-year-old child. He has also history of recurrent UTI and nocturnal injuries. So you can see the two collecting system on either side. Two ureter may be seen, and you can see that upper pole myopathy may show the hydronephrosis sometime, and you know that possible ureterocele at the bladder can be also. So I request from the audience, can anybody can search the Wegat-Mayer rule for me? Wegat-Mayer rule. Are you aware of the
The
Wegat-Mayer
weg
rule, Brother Akil?
I have heard, but
Hello.
I
Okay,
don't
tell me please.
remember the exact. But I think the ureter, which is inserted in the lower pole in the inferior lateral portion of the bladder, that has some relation with VUR, and the ureter which is inserted in the in the upper portion of the bladder, that has some relation with the posterior urethra, but I don't remember the exact. Just please confirm it. You have told it in a lecture, but
Okay, so there was a scientist. It is Wegat-Mayer rule. So there are two ureter in Wegat-Mayer rule or duplex system. So upper pole, the upper pole moiety of ureter, it actually inserts more midly and more inferiorly. So it starts upper and it is inserted downstream. So this is the upper pole meoty, and the lower pole meoty, it is usually inserted more laterally and the superiorly. So you should remember that the upper pole ureter should be too long because it is starting from the upper area and it inserting into the most inferior area. And
Okay.
the lower ureter should be very short because it is starting from the lower area and it is ending at the superior area. Okay. So upper is longer and lower is shorter. So upper ureter has more history of reflux nephropathy, and lower ureter can be blocked by ureterocele.
Okay, so the ureter
Okay.
which is in the
So
superior portion
make
of
it my
the
rule. I
bladder.
hope you will remember.
Okay.
This is the reason that you can see the hydronephrosis on the upper pole ureter.
So the ureter, just a repetition here.
Okay. So again,
So
what is the diagnosis here, brother?
this is again
Yes.
this is
Here
again a
again,
duplex
you
ureter.
can see the duplex ureter system. Thank you, Dr. Ali. So anybody can tell me what is the problem here? It is written clearly here. No, Dr. Mujib, it is written intravenous urinogram revealing a non-functioning kidney. So which kidney is non-functional on the A side?
The left
And on the
kidney
air
is
side, this is the left
non-functional.
kidney.
We cannot, yes, we cannot visualize any kidney on the left side. And okay, and on the right side, and the picture B, we cannot see any kidney on the right side.
Right
So there
side.
can be
Yes.
congenital absence, or there can be complete loss of the kidney. Okay, or there can be too much severe renal artery stenosis that has lead to because no contrast has reached the kidney.
Hmm.
Okay, so here anybody can read it. What is it showing here? It is showing the blackish area of necrotic papilla in the lateral minor calyx producing a ring sign. So ring sign in nephrology, what is the diagnosis of ring sign?
Papillary necrosis.
Capillary
In
necrosis.
nephrology, there are two signs.
Ah,
Yes, in papillary necrosis, there is a ring sign. And in cortical necrosis, there is a REM sign.
REM sign. Ah.
Okay? REM sign is in the cortical necrosis because whenever there is a too much ATN or dehydration, then in pregnancy related AKI, all the blood supply of the cortex has been put off, but some of the cortex just beneath the capsule is alive due to the penetrating vessels from the capsular area. So it leads to a viable REM in the cortex that is known as REM sign in cortical necrosis. Okay, brother. So ring sign is present. So what are the causes of papillary necrosis, brother? I want to listen 5 causes of papillary necrosis.
Analgesic nephropathy. Sickle cell nephropathy.
Yes, analgesic nephropathy, brother.
Analgesic
Analgesic nephropathy, stones,
renal stones,
TB,
tuberculosis,
stones, TB,
Sickle cell disease, tuberculosis,
diabetes,
sickle cell.
tuberculosis, and sickle cell anemia. Very
Yes.
good, Ali bhai. Sickle cell anemia as well. So you are telling very right. So coming to the next slide. So this is an important diabetes, pyelonephrotic, sickle cell disease. Thank you, Dr. Khashia. Your answers are 30-year-old patient
is
has history of
very
recurrent
clear.
renal stone and recurrent UTI. 30-year-old patient, history of recurrent renal stones and recurrent UTI.
This is dilated papilla هنا واضحة. Very clear. There is dilated papilla.
on the
Yes,
right or left?
contrast is filling the dilated collecting ducts.
Yes,
So
this is the
I have, yes, on the right side they are more
more
dilated, both
obvious on
sides
right
actually,
side.
but right side is more dilated.
More clear on right
So
side.
you can see a linear streaks of contrast extending into the papilla. So you can appreciate a brush like paintbrush appearance.
It's medullary spongy kidney.
Okay.
Yes. So sometimes it
Yes.
is described as a bouquet of flower, and sometimes it is called as paint brush appearance. So
Yes,
actually,
please
what
appear.
they call, so if you can see these end, so here it looks like some brush are there. Okay.
Yes.
So
Yes.
paint
Pocket
brush
flower.
appearance. So at the end, you should see paint
Hmm.
brush appearance. So when I have told you that 30-year-old patient with a recurrent renal stone and recurrent UTI, so in case of pulmonology, the disease bronchiectasis is
Hmm.
known as dilatation of the bronchioles
Hmm.
that leads to the repeated infection. In nephrology, dilatation of the collecting duct, just like bronchiectasis, it is a medullary sponge kidney.
Yes.
Okay?
Yes.
Yeah. So it is a type 1 RTA or type 2 RTA.
That is type 1.
Type
Type
1,
1
type 1
RTA.
RT. Is this the?
Incomplete type 1 RTA. Okay, right.
Yes.
So it is a medullary sponge kidney. So can you tell me that which type of nephrocalcinosis it can produce?
Which
This is
type?
a
Calcium
calcium
phosphate
phosphate stone.
stone. Calcium
Medullary
phosphate stone.
nephrocalcinosis, medullary nephrocalcinosis or cortical?
Medullary.
Medullary. Oh.
Yes, medullary nephrocalcinosis.
And this is
Okay, right.
medullary sponge. This will lead to
Ne-
medullary.
Medullary nephrocalcinosis.
Nephrocalcinosis. Yes.
Okay, so it is I think, a little bit difficult question for you. So any pathology can you see on the right side?
Yes, in the lower.
62-year-old man, 62-year-old
Yes.
old man presented with grass painless hematuria.
Hmm.
There is a blackish
56.
area. Blackish area in left lower pool, right
Age.
lower pool of the
What is the age of
kidney.
the patient?
62-year-old smoker present with painless grass hematuria. You can see there is a filling defect
Mass.
within renal pelvis on the right side.
Renal cell carcinoma.
Yes, it may produce a goblet sign. So it is called as goblet sign. So it is actually upper urinary tract urothelial carcinoma on the right side.
Oh.
Okay. So they can give you as well this type of nephrogram where they can show you the urothelial carcinoma. Okay. So I am adding the more slides. Just a minute. Okay. So anybody can tell me what is the name of this study?
This is a ultrasound
Ultrasound.
on the
Yes,
Pilot
right.
it's
Doppler.
yes, it is a normal ultrasound, normal renal scan. So there is a 35-year-old patient. He has history of microscopic hematuria and RFTs are normal. So is this kidney normal? Yes, we should be checking the kidney size, smooth renal contours, and preserved corticomedullary differentiation because medulla has more fats and it look a little bit whiter. And cortex should be not ecogenic. It should be just comparison to the liver architecture a little bit. It should be not white. So increase in whiteness is increase in ecogenicity. So grade 1, grade 2, grade 3, grade 4 ecogenicity is progressive CKD look. So there should be no hydronephrosis, no obvious calculus should be visible, no focal mass, any tumor or no abscess should be there. We should also be seeing the perinephric space for any collection or any hematoma. Okay, so it is you should never just say that it is a normal kidney, but you should comment on the size and the ecogenicity, the corticomedullary differentiation, the visible collecting system, any focal lesion and stones, and also comment on the bladder whenever possible. Okay, so sometime in a uh, exam and tox exam, they give you probe and they tell you to scan the kidney and they tell you whether you can do the biopsy or not. So coming to the next slide. So here, what is the what you are seeing actually?
We can see
58-year-old hypertensive patient, creatinine of 5.2 milligram per deciliter, long history of hypertension, HB of 8. There is no significant proteinuria. Okay.
of CMD.
Yes, here is a grade 4 echogenicity and corticomedullary distinction is faded off. So it is a picture of a CKD kidney actually. Okay. And if you measure the kidney size, it should be.
I am comment on this. The cortex is very clear, Dr. Ghaswar.
Yes, brother.
Cortex is demarcated from the medulla, but there is some of the.
You are right. So it is a grade 2 echogenicity, not grade 4. So this patient should have creatinine of 2.2 or 2.3 roughly, but it is developing CKD actually.
the cardiac echogenicity is equal to the liver. So this is grade 2.
Okay, so
compare.
here you can see brother is telling right. So in a CKD, here is a complete loss of cortex and medulla.
Okay, very clear.
On the left side.
It is a complete loss of cortex medullary differentiation, and this should be patient of hemodialysis, or he may be undergoing imminent hemodialysis.
Salt and pepper appearance.
Okay, so coronary parenchymal disease, advanced CKD, and shrunken kidney. Okay, so what are the DD of on the right picture? It can be any glomerulonephritis because the size is normal. We cannot see as a amyloidosis, but we can see like it can be due to the any GN acute or chronic interstitial nephritis or something like that.
I have a question, Dr. Gaswar. I have a question.
Brother.
Is it better to measure cortical thickness or all the kidney thickness?
No. You have to tell the three things. You have to tell the length, width, and cortical thickness alone.
And the CMD.
Okay. So you have to measure just this thing, cortical thickness. Okay.
We have a patients. I see the patients who have a total kidney length is a small, but the cortical thickness is a good with the normal kidney functions.
Nice. So yes, you are right. Sometimes there are small kidney congenitally, but they are working very good.
Okay.
So anybody can tell me what is being showing here? It is written there. So it is a hydronephrosis, grade 1, grade 2, and grade 3, and it is a grade 4 to 5 thickness. So there are usually 5 grades of grade 1, grade 2, grade 3, and grade 5. So similarly, you should be able to tell when that they give you picture of ureter. So can you tell me the 4 causes of this condition?
It can be any stones, any tumor.
Yes,
VUR.
that can be stone, that can be tumor, that can be VUR, that can be retroperitoneal fibrosis.
Divided intraluminal, luminal, extraluminal. Luminal, stone, granuloma.
Luminal and extraluminal, yes.
Like stricture.
Okay, yes. Very nice.
Extraluminal tumor.
Extraluminal can be tumor, retroperitoneal fibrosis.
Retroperitoneal fibrosis. This is extraluminal.
Gravid uterus. Okay. So you are very right, brother.
Gravid uterus,
okay.
Possible, yes.
Okay. So next, what is it is showing? So it is written here. So renal calculus will be always showing a shadow, posterior shadowing. Okay. So it is a picture of stone. Okay. So calcium dilation, lower pole of the right kidney, stone with a posterior shadowing. You can see the black shadow.
To differentiate between the hydronephrosis and cystic kidney disease, there is a connection between the cyst. If there is a connection between cyst, this is hydronephrosis. If there is no connection, this is going with cystic disease. Agree with me?
Okay. Good point, brother. Good point.
If there is a connection, then hydronephrosis. If there is no connection, then there are cysts. Okay. Good.
Okay. So it is a. If you will apply the color Doppler on the stone, if it has posterior shadow, it will show the twinkling artifact. So remember this point because the examiner are very interested to hear about when you are confused either it is tiny stone or not stone, then you should apply the color Doppler, and it will show you the twinkling artifact.
Twinkling artifact. Okay.
Okay.
Twinkling
So,
artifact. Okay.
twinkling artifact can confirm that this is a case of stone. It will confirm the diagnosis. Okay.
Oh,
So what it is showing, renal stone with the shadowing. So you
yes.
should be telling the size of stone. You should be telling any hydronephrosis and any abscess or infection or any xanthogranulomatous pyelonephritis. So be very careful. It is stone showing hydronephrosis as well as posterior shadow. Yes. So what is the diagnosis here?
Huh?
What is the diagnosis here? It is simple, renal cyst. Okay.
Okay. We were thinking about the
Difficult.
blood.
Okay. So
Not complete picture.
yes, it is not complete picture, but here you can see clearly.
Yes, that's very clear. Yes.
Okay. So anybody can tell me the Bosniak classification of renal cyst?
Stage 1, 2, 3, 4. Stage 1, there is a benign, less than 3 cysts. Difficult to remember. The Bosniak cyst is blind for the queer-cystic kidney disease.
There are basically 1, 2, then 2F, then 3 and 4. In
Okay.
class.
Class 2, class 2A, class 2B, class 2C.
2F. 2 and
No,
2F.
no.
Okay.
Yes, Akil is right, brother. Here, Mohammed, brother. One is simple cyst. There are no septa.
There's the
And,
answer. There's the
it is a
answer.
minimally complex. And stage 2, when there is there can be fine septa, but there is no enhancement, and it is less than 3 centimeter. When 2F is there, it is almost 3 centimeter, and there can be little bit enhancement and 10 to 30% chances of cancer. So you should follow it after 3 to 6 months. So
Yes.
stage three is measurable enhancement. So here you can see the enhancement at the lower pole, posterior equistic enhancement. So whenever there is an enhancement, it is more than 3 centimeter, it is a stage 3 or 40 to 60% chances of malignancy. And the stage 4 is a clear-cut malignant. Okay. So you should be aware of
Invasion.
Bosnia classification. Okay. So yes, again, what is this is the patient, creatinine of 2.8, BP 180 by 60.
Polycystic kidney disease.
Basically,
Autosomal
multiple cysts.
dominant polycystic
Yes.
kidney disease. Yes.
There is
There
no
is
connection.
there is some of enhancement here.
And there is no connection between the these densities.
Okay,
I
so
wouldn't
can
say
you tell
yes.
me the revised unified criteria?
In the revised unified criteria, between the ages 15 to 39, we should have a total of 3 cysts in both kidneys. And if
Let the pastor family history. I want to listen it.
Without family
with
history,
family
you
history,
need
with family history, yes. Between the ages of 15, when the patient has family history, and between the ages of 15 to 39, we must have 3 cysts in both kidneys, either one kidney or the other kidney, but we should have three cysts. And if the age is 40 to 60, then there must be 2 cysts in each kidney. And if the age is more than 60, then there must be 4 cysts in each kidney.
Please,
And all these must have
doubt.
families.
I am doubt
Can you
about
tell
age
me
from the 15
use of
to
tolvaptan?
the 39. Is this cyst bilateral or unilateral?
Cyst unilateral or bilateral? Sorry, unilateral.
Oh, enough. Unilateral is enough. I think so.
3 cysts in both kidney, making a total of 3. It can be 1 in one kidney and 2 in another kidney, making 3 in both kidney. Total of 3.
Okay.
So it is 324 EE. So EE mean in each kidney for 2 and each for 4 in each kidney. So there is no E in the position of 324. So 324, you should write EE below the 2 and below the 4.
Okay.
So each kidney for 2 and for 4. Okay, so Again, it is autosomal dominant polycystic kidney disease. Here you can tell me what is being shown here.
There is a mass here. Mass in the upper pole of the kidney.
Yes, it is a mass in the upper pole of kidney. So you can see a rounded mass. So it can be renal cell carcinoma or acquired cystic kidney disease tumor. When the kidney is neurogenic, then it can be acquired tumor. But there should be some cyst as well. But here it is a clear-cut renal cell carcinoma. So can you tell me a single drug to treat the renal cell carcinoma?
What?
There was, I was just.
Any drug to treat renal cell carcinoma?
That is one single drug you have repeatedly told us.
Sunitinib.
Sunitinib, yes.
Tyrosine kinase inhibitor. It is a CML. We use also in CML that can be nilotinib, dasatinib. Okay. Imatinib. So here we use sunitinib most commonly in renal cell carcinoma. So this is again the picture of same patient that is showing increased vascularity. So 62-year-old man presented with hematuria, weight loss and flank discomfort. There is focal renal lesion is seen in the upper pole. It can hypoechoic and usually heterogeneous mass that can be solid or complex. So it is a renal cell carcinoma.
This is a Doppler study.
Yes, it is showing increase in vascularity in the cancer area.
Okay.
So again, you can see a mass.
Yes.
So it can be renal cell carcinoma again.
On the right
again,
side.
you are showing a mass here.
Yes.
So we are trying to make differential diagnosis in your mind. So you should be very quick to answer at the TOX examination. So it is a patient ultrasound reporting showing mild hydronephrosis, no pain, normal creatinine, no stain, no hydrogenator. Okay. So ये hydronephrosis है और when there is a hydronephrosis with the dilated bladder, what are the differential diagnosis?
PBH.
That may be urethral stricture or posterior urethral
Bladder stone as well.
wall. Bladder stone.
Bladder stone at the neck, prostate.
Yes.
Prostate,
BBH?
yes.
VUR.
No,
Urethral
posterior
without the
urethral wall.
stone?
Posterior urethral wall.
Posterior urethral wall and reflux nephropathy.
Okay.
Okay, reflux
Neurogenic bladder. Neurogenic bladder.
No, with distended bladder, VUR can present with the distended bladder.
If there is
Neurogenic
a
bladder.
if there is a neurogenic bladder.
Okay.
Due to diabetes or meningomyelocele or any history of trauma or diabetic neuropathy or advanced amyloidosis. Okay.
Yes.
So there can be pelvic mass in female as well. You are not telling the cervical cancer. So if the bladder is empty, but there is a bilateral hydronephrosis, then can be retroperitoneal fibrosis. Okay, this was the patient who presented with the repeated UTI and 70-year-old male. When the catheter passed, it led to the 1800 ml of urine. So what is the diagnosis?
Urogenic bladder.
Yes.
70-year male. So it was prostate, brother. First thing, the common things.
Yes.
Prostate is common.
First thing, the common things.
Prostate
Okay.
is common, yes.
Okay, so acute retention of 55-year-old man. Again, it was a case of the, the prostatic enlargement. So here it is a renal transplant kidney. We are trying to visualize the vessel. So renal artery, that should be coming from the external iliac artery. And the renal vein, that is anastomosis with the inferior vena cava. Okay. So here what you can see, brother, this is a difficult slide. When you are saying extrarenal pelvis. It should be, it is a cyst or it is a hydronephrosis?
Cyst.
There is no connection, so it is these looking cyst.
No,
Not so
brother, it is
difficult.
hydronephrosis.
I don't know process.
Not difficult.
This is a cyst here. This
Okay.
patient presented with the history of which he has diabetes and now swinging fever for last 10 days. TLC is 28,000. So it can be abscess as well. Okay.
Okay.
So whenever you find any collection, it can be mass, it can be infected cyst, it can be abscess. So you should be broad minded. So your
This is
mind should be open
on
for the
the
differential
left pole
diagnosis.
showing an abscess. On the left pole.
Yes, left, no, it is on the lower pole, lower pole.
Okay. On the left side.
Pathology kidney.
Okay, so here it is a renal transplant patient who has peak systolic velocity of 245. So anybody can tell me the normal velocity?
180 to
180.
200.
Yes, 180 to
180.
200. When is the 345 velocity? So it is showing the renal artery stenosis.
We measure stenosis by the resistive index. Resistive index,
Resistive index. Yes, so what is the formula of resistive index, brother?
which equal a difference between the diastolic minus systolic minus systolic over
Divided
systolic
by?
velocity.
Okay. So resistive index. So what happens to the resistive index in renal artery stenosis? It is increased
More
or
than
decreased?
0.7. More than
Increased.
0.7 indicate renal artery stenosis.
No. I don't agree.
More than
So
0.7.
Increase.
Increased.
no. In a renal artery stenosis, the periphery is deprived of blood. So what happens? It leads to a state of vasodilation. So all the peripheral vessels are vasodilated. So resistance is always decreased in acute renal artery stenosis.
Okay.
Beyond the resistance, renal artery stenosis may, yes, the resistive index is decreased in renal artery stenosis because the peripheral vessels are that are dilated. So you can see here, you can see arteriovenous fistula. So at the anastomosis site, if the radial artery is sending blood to the hand, if the radial artery is sending blood to the hand, normally there is too much capillaries, palmar arches, so there is a too much
I have
resistance.
direct
Once
connect.
if best when the blood is coming to the venous segment of the arteriovenous fistula, you know that the pressure in right atrium is zero. So pressure in vein is zero. So resistive index is quietly decreased in AVF as compared to the distal vasculature of hand. So similarly in renal artery stenosis, the resistive index is decreased due to the too much vasodilation due to the ischemia. Okay. अच्छा, अगला बताएंगे. What is this, brother?
How to agree with you, Dr. Aswar?
Calcifications.
Calcification. Yes, you can see here.
Okay.
So what is the terminology for this?
Nephrocalcinosis.
Nephrocalcinosis.
Yes,
Nephrocalcinosis, yes.
nephrocalcinosis. Okay, so
Nephrocalcinosis.
it is cortical or medullary?
Medullary.
Yes, medullary nephrocalcinosis. So
What?
can you tell me the 12 causes of medullary nephrocalcinosis? There are
Reactive
the 12
acidosis type 1, RTA type 1,
renal tubular acidosis type 1,
RTA.
hereditary hyperoxaluria, idiopathic hypercalciuria syndrome, hypomagnesemia, hypercalciuria syndrome, rapidly progressive osteoporosis, dent disease, acetazolamide, amphotericin B, triamterene, furosemide in children, and other is the vitamin D intake, sarcoidosis, calcium intake. Okay. So
Hypercalcemia, hyperoxaluria, like this.
primary hyperparathyroidism, yes.
Yes.
So
AHH.
FHH, AHH.
FHH or AHH?
पता नहीं यार, AHH होगा.
Because AHH has hypercalciuria.
Hypercalciuria. Okay, okay. So what are the causes in cortical nephrocalcinosis? GOAT. GOAT, GOAT. G for glomerulonephritis, O for oxalosis, A for ATN, T for transplant, T for TB, T for trauma.
Okay, this is abbreviation is good. Okay.
GOAT. Yes, yes, brother, GOAT. So again, you can see the medullary nephrocalcinosis here. So hereditary hyperoxaluria type 1 is also included here. Okay. So here you can saw the beer pass sign on the CT scan. So what is diagnosis?
Xanthoglomerulitis.
Xanthoglomerulitis.
Pyelonephritis.
Glomerulonephritis, you can see the stones in the kidney as well. And beer pass sign,
This is bumpy kidneys.
bumpy kidney. Okay. So what are the differential diagnosis of large kidney? 6 differential diagnosis of large kidney.
Diabetic kidney disease, HIV,
Kidney disease, HIV, amyloidosis,
amyloidosis, pyelonephritis.
pyelonephritis, ADPKD.
Yes.
Hydronephrosis, any
Okay.
unilateral.
Infiltration, whatever.
Inflammation with the tumor. Okay. Okay. Renal cell carcinoma and any other peripheral tumor. Okay.
Okay.
So it is a Staghorn's to white stone. So what is the diagnosis treatment option for this white stone?
Surgery.
Surgery and repeated antibiotics for for too long period.
Is a urase inhibitor, but not applicable. It's hydroxamide.
Acetohydroxamic
Hydroxamide
acid,
is a
acetohydroxamic
drug,
acid,
but not
and repeated.
applied clinically.
What is
But
the
written in literature.
the second magnesium ammonium phosphate of white stone? Magnesium ammonium phosphate stone. वो यही होते हैं कोई और होते हैं भाई?
यही ट्रिपल फास्फेट यही होता है.
Okay, so acetohydroxamic acid.
Magnesium phosphate is provide.
Urase inhibitor.
So what are the 6 organisms that are most associated with this type of stone?
Klebsiella, Pseudomonas, Ureaplasma ureaticum.
Ureaplasma ureaticum, Proteus.
Yes.
I think E. coli is not included here. Okay.
Morbalis, yes.
Enterobacter.
E. coli not included. E. coli not included, yes.
What is here diagnosis? ये तो मुझे खुद भी नहीं आता
Again,
यार.
these are the gas
Yeah.
shadows. Huh?
Yes, it is emphysematous pyelonephritis, brother. It is very difficult to pick on the ultrasound, but when you see the CT scan, you can see the air. So it is emphysematous pyelonephritis.
Yes.
Okay. So what are these gas-producing bacteria? Can you name them?
You have
E.
already
coli.
told the names.
Klebsiella.
That is the Klebsiella, Pseudomonas.
वो यार अकील check कर लो. They are different for the white stone and they are different for the air production. So kindly remember, you should search here. And अली भाई सबको बताओ ना. अली भाई कहाँ चले गए आप?
If someone remember, then please tell. Exact. With the mnemonics if possible.
So this patient presented with a diabetic patient presented with a high fever, flank pain, sepsis, and AKI. सारे खत्म हो भाई जान. आगे चलो भाई. Ultrasound of renal TB here. So hypoechoic areas in the renal cortex suggestive of caseous necrosis. So there should be history of raised ESR, TB contact, unvaccinated, and endemic area as well. So Here the bladder is getting calcification slowly and slowly. So infection of some parasite. So can you name that parasite?
Trophomiasis.
Schistosomiasis.
Yes, so finally it will lead to the axial
Hematobium
calcification.
schistosomiasis.
Schistosoma hematobium. So what is the
Hematobium
treatment?
schistosomiasis.
Muhammad
Hematobium,
brother,
yes.
what is the treatment of schistosoma hematobium?
Prazaquantil, this is endemic disease in our country. Prazaquantil.
Quantum.
Hmm?
It is common in your country, brother?
Yes, it's a common, it's endemic area here in Sudan.
Okay, so in Pakistan, I have not seen any patient, and there is we have found the drug. It is not available. Praziquantel is not available in Pakistan. So any other drug to treat it?
Antimony.
Here it's available and free here. Prazaquantil.
Acha, it is freely available.
Free available.
Okay, so if I need for some patient, I will contact you, brother.
Okay, no problem.
Thank you. So are you attentive to attend the more slides, or we can convert to the next lecture?
Okay.
It
अकील
depends
भाई
on
अभी शुरू करें अभी रोक दें
कितने टाइम हो गया
Well,
1 hour हो गया ना बस फिर क्लोज कर
Okay, I think we will cover in the next class the remaining things.
inshallah.
Inshallah.